And if I'm not getting as much circulation to the skin, it's going to feel cool, right? And because of cholinergic responses and stuff like that, you're going to feel clammy, which is actually a little bit counter because you're losing some fluid here, so that's kind of not as helpful, but it's just what happens, okay? My heart is elevated, okay? But so far, I've still got a good bounding radial pulse, but it's fast. It's about 120, okay? But it still feels pretty good, all right? My skin's cool and clammy, but what I don't see going on behind the scenes is some of this internal backup systems going on. The renin-angiotensin system, the aldosterone system, activates the release of the antidiuretic hormone, which is something that occurs in the kidneys. The kidneys tell the brain, the pituitary gland in particular, you need to release ADH, antidiuretic hormone, okay? And so the ADH, or the antidiuretic hormone, tells the kidneys to quit producing what? Urine. Okay? It actually starts to shut down your kidneys. This would be why in ICUs and in the ER, we have a tendency to put in Foley catheters and measure urine output. Why is that important? It lets us know where we are in our whole system of backups. We monitor urine output. Do you know what? If I've got a good urine output, I haven't hit this yet. Okay? My brain doesn't perceive things bad enough right now that it's shutting down my kidneys. Or not my kidneys particular, but my urine production. But this is why we measure urine output. It's because, have we hit this cascade yet in our backup systems? Okay? So we have antidiuretic hormone release. Did you know your kidneys actually have the ability to take fluid out of newly forming urine, hasn't quite become urine yet, and actually move it back into the system? Pretty smart, I think, okay? The initial compensatory mechanisms increase. So again, we see an emphasis of this sympathetic nervous system response. So our heart rate just kind of keeps going up. Okay, it's trying to do all of this. And we actually have an autotransfusion effect that allows the body to compensate for a volume loss up to 25%. What's happening here? Why is all this happening, and what is the main goal of the body to do this?
Perfuse the blood.
To maintain your blood pressure. Okay? Yes?
Question about the second one. When it says increased preload, what is it that the body is doing to do that? Obviously, it's kind of
It's to increase your volume. Okay, so the preload is the volume coming into that ventricle to provide that stretch.
So, I mean, that's kind of like a downstream thing of the stroke volume, right? But is there something happening in the veins that's increasing preload, or?
Absolutely. So as we think about our picture, okay, so if we've got veins, okay, that have this much blood in it, okay, and so that maintains a certain pressure right inside that ball. All of a sudden that vein becomes this side, and you have the same amount of volume in there. What does that do to your pressure?
Higher pressure.
Higher pressure. It's all to maintain your blood pressure, okay? And when we talk about this autotransfusion effect, did you ever wonder what your spleen does besides kind of filter and whatnot? Did you know your spleen actually has the ability to give you a little bit of a transfusion? It dumps red blood cells into your bloodstream. It actually gives you a little bit of an immediate transfusion reaction. And all of this is occurring to maintain your blood pressure. So if you come into a patient and you're suspecting, an injury that could lead to shock, and you're seeing some of these initial signs, okay? Pale, cool, clammy skin. They've got an elevated heart rate. But you then go, yeah, but my blood pressure is 120/70. I'm good. Are you good? Maybe for a minute, okay? You're compensated. That is a compensated shock, okay? You've got it, here's where you've got to recognize the train coming before it hits you, all right? You've got to recognize these early symptoms of what your body is going through to maintain its perfusion. All right, it's going through all these little backups to make sure that it's okay. It's constricted the vessels to up the pressure, okay? It goes through this autotransfusion. It's released the antidiuretic hormone, which you're not seeing, okay? But just know that all of this is occurring in the background. It's actually pretty amazing. If hypoperfusion persists, okay, because maybe we're just not as good an advanced EMT as we should be. You know, we see these symptoms, but we measure our blood pressure and we go, my blood pressure is still 130 over 80. I'm good, okay? And we're failing to recognize all these little subtle things going on, okay? So if hypoperfusion persists, the myocardial function will worsen, decreased cardiac output and ejection fraction, both will start to go down, okay? Little Johnny's still bleeding out from his spleen, all right? He's still bleeding out. Tissue perfusion decreases, okay? Now, we're not only not having as much blood going to the bloodstream, we not only have constricted vessels in our skin and muscles and stuff, etc., but now the blood is inadequate and it's not carrying the oxygen that it's supposed to because there's just not enough cells there to transport that oxygen. Our lungs may be working just fine, okay, but our blood's not there. The volume is not there. And again, we're using the example of a hemorrhagic shock. You can have leakage of the fluid from the blood vessels. What's a type of shock where you can actually have leakage of fluid from the blood vessels? Septic shock. Yep. Have any of you ever experienced or gone up to see someone in the ICU and they're just like swollen up? Okay, it's called blood spacing. Stuff just leaked out. Just leaked out into the extra. You can have someone who, they are so swollen. Okay, they're so swollen, but yet they're actually volume depleted because all of the volume is not inside the vessels where it's supposed to be. It is leaked out into the extracellular level. Okay, perfusion to the brain and coronary arteries start to decrease. Okay, I don't know about what your thought processes are, but I'm thinking that's bad. Okay, cells switch to an anaerobic metabolism. Okay, we're supposed to be all aerobic, right? Meaning we're using air, oxygen to metabolize. We switch to an anaerobic metabolism, and we have the production of epinephrine and norepinephrine. What does that do for us? It's kind of the last little boost to just try to keep things going. Epi is a stimulant, right? Neurotransmitter. A production of epinephrine and norepinephrine, which helps to try to keep things going there. So there is a pecking order. Okay, again, we talk about which organs are the most stingy, wanting the blood. So plan shunting of blood from areas of lesser needs to areas of greater need. Again, it's going to shut down, your brain's going to shut down circulation to your skin, to your muscles, because it knows that it's a lot more important. All right, so again, as you think about this, think about the signs and symptoms that you're going to see as this shunting effort is made to keep up perfusion. Failure of these compensatory mechanisms to preserve perfusion results in decreases in preload and cardiac output. In other words, when you've run out, you will see the end results of the shock patient.
Can you go further into that?
So a lot of it has to do with the type of waste products that it develops in an aerobic metabolism. You have a normal byproduct that your body is able to get rid of. In an anaerobic metabolism, the byproducts, it causes a metabolic acidosis, which then further damages the cells. So it's just not a normal process. Many of you have worked out really, really hard, and your muscles have been so sore the next day that you could hardly move. that would be because you built up, you probably went into more of an anaerobic metabolism. The byproduct of that is a lactic acid. You then get like a lactic acidosis, and that's what builds up in your muscles and your nerves. So it's an abnormal metabolism. So shock-related events at the capillary and microcirculatory levels. Okay, cellular ischemia occurs with decreased perfusion. Okay, what is ischemia? Okay, it's just lack of oxygenation. Okay, it's oxygen deprived. So occurs with decreased perfusion. So again, we just don't have the circulation to that area. Anaerobic metabolism. Here we get into that a little bit more. Results in systemic acidosis and depletion of the body's normally high energy reserves. So now we're getting down into like the ATP, which is our energy, okay, our ability to use that energy. Incomplete glucose breakdown results in accumulation of pyruvic acid. So this is the metabolism of glucose. It results in the accumulation of pyruvic acid. So again, we start anaerobic metabolism leads to a basic metabolic acidosis. So cellular flooding explodes lysosomal membrane and releases enzymes. So again, I'm not that concerned that you understand, the whole microphysiology behind it. I want you to understand the basic physiology, that as this lack of perfusion occurs and we get down to the cellular level, that it can cause effects that may not be seen for weeks, okay, and can lead to other problems, including DIC, etc. So the continuing buildup of lactic acid and carbon dioxide acts as a potent vasodilator. Okay, so I want you to think about that in the physiology as we look at our bloodstreams, okay? So all of a sudden now we're getting into a metabolic acidosis, okay? So we've got this buildup of lactic acid and carbon dioxide, all right, and it becomes a potent vasodilator. Okay, so think of our vessels that are trying to constrict. We've got our blood here, okay, which now is going down because I'm losing some of that blood. Okay, so my vessels are trying to constrict, but my blood that used to be full is now down to here, and now I'm having this continual hypoperfusion, and vessels that were this big are suddenly now this big because of this lactic acidosis and the pyruvic acid and CO2 causes massive vasodilation. My blood was even getting low in my little vessel, and so now where's it going to be in my big vessel? Okay, what are you going to see? A patient who's dying. Okay, your blood pressure is now 60 over 30, and well on their way out. So again, it's just this cascade of effects that happen as the backup systems run out.
So in the ICU, or their blood pressure is getting very low, do you do blood transfusions to get
Yeah, we do both. So a lot of it is identifying what type of shock it is. Is my main problem volume loss, or is my main the circulatory system, as far as if my vessels are intact? So if my main problem is blood loss, I can give all sorts of vasoconstrictors, but it may not help as much. What do I need? Blood. Okay, I need blood. And so then we will treat with blood. If the main problem is sepsis, and I've got this huge metabolic acidosis going on, what is most likely my main problem? If I have a metabolic acidosis related to sepsis, what's my main problem?
Arteries.
The vessels have dilated. So what would be my treatment for that? Vasoconstrictors. Okay, to try to get those vessels back down to where they need to be, to kind of counteract what the body is doing in its low perfusion state. Okay, so then I'm running norepi, I'm running, the levofeds, dopamine, the vasoconstrictors, okay, and it's a balancing act, okay, do I have enough volume? Sometimes if we get too much volume, that's when we see a lot of the third spacing. So we want to keep our volume down, but we want to keep our vasopressors going. And we're shooting for a mean arterial pressure that is adequate to perfuse the kidneys. So here, and how do I know if we're adequately perfusing the kidneys? My urine output. What's my urine output doing? Okay, kidneys that are not healthy don't produce urine. Okay, but if I've got an adequate, good urine output, then in my mind I'm thinking, okay, I'm playing this balancing act, and I've got, I'm just walking that wire of making sure that I'm treating everything that's involved here. White blood cells and blood clotting systems are impaired. Okay, this is where you start to see breakdown in the whole clotting system. It just doesn't work right. Okay, you'll see. Have you heard the term DIC? This person's gone into DIC. This person basically goes into this cascade of where they don't have the ability to clot normally, and they'll start bleeding out of old IV sticks. I mean, they just start bleeding everywhere, out of every little hole and puncture and ruptured capillary and whatnot. They start bleeding. Okay, this is a late effect of this cascade of hypoperfusion in this shock cascade, it's found to complicate septic shock. Yeah, no kidding, right? When you're bleeding out of even IV sticks, that's a bad thing. I'll give you a break here in just a minute, okay? Okay, so we're progressing on. All right, so this is just a continuation. We started with the early signs, and we're now getting down to where things are not good, okay? Multiple organ dysfunction syndrome. Basically, this is where things start to fail, okay? Progressive condition characterized by combined failure of several organs. If the kidneys are not getting the perfusion that they need, okay, those are one of the most sensitive organs in the body and one of the first ones to start to fail. So that's when we start to see evidence of renal function failure. Okay. So, and what's going to be the first thing that we're going to physically see? Again, the decreased urine output. Okay. It could be initially because of the antidiuretic hormone decreasing it, but then after we get them volume, we should set that back up. If we don't see that coming back up, we're probably gone into renal failure because of the poor perfusion to the kidneys. The kidneys have started to shut down. You'll also start to see just the whole cardiovascular system fail. You can have massive pulmonary edema, where all of a sudden the fluid's starting to flood into the lungs. So how does that affect your cardiovascular system and your perfusion? Not good, right? Now you're going to have an effect on the pump, and you've got an effect on the respiratory system. This occurs when injury or infection results in release of numerous inflammatory mediators, and again, this is a big physiological response, and you can have the activation of complement system, coagulation system. This Kili-Kinin system, it has a lot to, it's kind of a hormonal, not hormonal system, so I don't even completely understand it, but I know it has to do with also the factors involved with clotting. There's like a factor 12, and what is F in the numeral? Roman numeral. FX22, that's also one of the factors related, so it's like, I don't know any of this, so, but these are also systems that are involved that start to kind of kick in during these advanced stages of poor perfusion. So, multi-organ dysfunction syndrome, okay, as far as signs and symptoms, this is when you're going to start to see your low blood pressure. You're probably going to start to see your low blood pressure before, these final system failures. But you are going to see, obviously, the evidence of hypotension, insufficient tissue perfusion, uncontrollable bleeding. And you're thinking, well, uncontrollable bleeding, why can't you control the bleeding? So why can't you control the bleeding? when they get to the OR, we can try to control it, right? But they still have uncontrollable bleeding. Why is it? Because of our clotting factors. Because we've now gone into these things where our clotting factors aren't working right. So it doesn't matter how much strip pressure or whatever, you can put your turn count, but basically everything's just failing. They won't clot.
These are all late signs of.
These are late. Yeah, these are late. This is when things are failing.
Hopefully fatten on the next person by now, right?
Yeah, this is when they're dying in the OR. Not on you, right? That's always the goal, let them die on someone else. Okay. So multi-system organ failure caused by hypoxia. This is when you start to see evidence of the cardiovascular system failing, the kidneys are failing. Okay, what's their level of consciousness going to be like at this point? Yeah, they're going to be unresponsive. Okay, so this again is, we've gone down the cascade. All right, where we've got a little kick into the sympathetic nervous system, and now we've gone through all of these systems, and we're right now at the end. In other words, if you're circling the drain, you're right here. Okay, you're right there at the drain. Tissue acidosis and severe local alterations of metabolism. Nothing is working right at this point. Okay. So respiratory insufficiency in part of all of this. Obviously, insufficient concentration of oxygen in the blood can produce the shock. Okay. Poisoning may affect the ability of the cells to metabolite or carry oxygen. How's that? What kind of poisoning are we talking about here? So now we're kind of shifting a little bit. Okay, now we're just specifically talking about the respiratory's involvement in this cascade. Okay, so if you've got poor oxygen, all right, that will trigger all of these cascades quickly as well. So is this something that you can fix?
Yes.
Yeah, you get them oxygen, right? Yeah. Okay, so insufficient concentration of oxygen in the blood can produce shock. So, in other words, make sure your oxygen level is adequate. But when we talk about poisoning, that can affect the cells to metabolize or be able to carry oxygen. Carbon monoxide poisoning. If you've thought about that as an actual poisoning, that can cause shock. Okay, I mean, carbon monoxide poisoning, that it doesn't immediately trigger shock in my mind, but just realize that it can. Is the ability to oxygenate part of the cardiovascular system? And if that, now why does carbon monoxide poisoning affect oxygenation so much?
So it binds to the hemoglobin.
Yes, because do you know what? Your hemoglobin, your red blood cells and stuff actually has a greater affinity, in other words, a greater love for carbon monoxide than it does than oxygen. Okay? It's a little bit more stingy. It can just bind right on there. And so if that little molecule, that little blood cell is all covered with carbon monoxide, is oxygen going to be able to bind to that? Nope. All of the spaces have been taken. It's kind of like playing musical chairs. Okay? The molecules are dancing around that blood cell like a musical chair. And the carbon monoxide is going to get there first. Okay, so how does that affect? So if your body's not able to get that oxygen to the tissue, can you see how that can trigger these cascades of problems? Absolutely. Okay. Cyanide poisoning is also a poisoning that will affect the ability to oxygenate. Anemia. What is anemia? Low blood count, low red blood cells specifically, okay? Can result from chronic or acute bleeding, okay? So some people are chronically anemic. So if you're taking care of someone that you're concerned about maybe exhibiting some shocky symptoms, and you hear that they have a history of anemia, does that give you a little bit of a strike against you already? Yeah. And so do you see where your history kind of plays in here as far as your ability to assess this person and going, okay, so what are my risk factors here that this person could be going into shock? Okay. Well, I have a history of anemia. It's like, okay, so if I'm remembering that shock is a collapse of the cardiovascular system, which involves the heart, the lungs, and the blood, one of those three things in that perfusion triangle is already affected. the blood. Right, so I've already got one dean, and so I need to make sure that the other two things in my triangle are really, really kept at an optimal level, correct? So I'm just going to be very diligent about this. Okay, and so anemia can result in hypoxic tissues. I'm going to let you take a break. When we come back, we'll start talking about the causes of shock. So how about, let's take a 10-minute. Go stretch, get a drink of water, something, wake up a little bit. Like, right, you guys, that was the most difficult part of this whole lecture. Do you feel like, oh my gosh, my hard drive is full, I need to go install some more RAM and come back, okay?
Great job. Thank you.
These guys are actually being nice to the
It's because they've been threatened.
Yeah, we're under orders. But who's counting?
Yeah, yeah, it is. But it's time. Yeah, he does all of the public relations stuff. He's done that for a year. He hasn't flown for close to 10 years. No. Chris has been gone for a year and a half. Yeah, she kind of bounces around. Oh, hell.
Oh, crap.
That was 10 years ago, that started.
I got my little letter from home, see, you're out, eligible for retirement.
Oh, I gotta sign up for Medicare.
You are old.
Well, I am. I've been getting all this stuff in the mail, and I got this card from Social Security.
Mhm.
You're 64 3/4. You gotta sign up for Medicare. No, you need to sign up for Medicare. I'm going, so I've been going through all of that, but I found out I really don't have to sign up for it.
But
Because I'm employed with insurance. That's all they care about. Well, if you have insurance, they don't care.
You're good, yeah.
Yeah. But, yeah, so. Oh,
I mean, you go to any of the big department country like that, and that's, you can't get it. And you don't understand
I fought that for years, and nobody will listen.
You all jumped on that bandwagon.
Oh,
Do you know what I mean?
Well, I tell all these young guys when they're coming on, I said, quit worrying about your 2% raise a year.
Yeah.
You better fight for post-retirement medical insurance.
It's the whole reason.
Is that what you Yeah, well, me too. Yeah.
Okay, does he stay working just 8 to 10 shifts a month, or do I go back to work 36 hours a week?
Right,
You know,
right.
at the bottom of the total bill, because he's doing that now, you know.
Yeah. Yeah, they keep fighting for more money raises, and so they throw this little carrot out there. We'll give you 2%.
Oh, yeah. It doesn't even keep up with the cost of living.
No. No. Every time I go to IMC, I don't know.
I don't either.
I
I
walk
watch him
in.
and look around and go, who are these people?
Right, yeah. You know,
You know where I am in seniority? No, but I'm 137 years.
Yeah.
I'm number 4.
Yeah. Yeah.
From the original LES crew that came there, I think there were only 3 of us left. There's myself, Ian, and Dave.
Oh, okay.
That's it?
Yep,
From the original LES crew.
yep. Yeah, I see Leanne every once in a while. And I can't remember the last time I saw Blake. It's been a while. Well, I work nights and so, and now that I'm not working on the engine, yeah, I've got 4 shifts left. 4 or 5. They just had their 40th anniversary. That was, yeah, that was pretty cool. It was fun seeing a bunch of the people who retired.
I still remember when you doesn't go, you know, like in the old English genre.
Oh, yeah.
And we did the sound of
With
music.
Harry Wiley.
Yeah.
Huh? When it was Sound of Music.
Sound of Music show.
Yeah. Up City Creek Camp.
Yeah.
Yep. Yeah.
And I remember one, I can't remember if you were on that part of the conversation out of his family. And it was middle of July, it was the old orange Alouette. And I remember, couldn't get off the ground, it was too hot. And throwing an alarm, and his husband was out to try and get off the ground.
Yeah.
And the patient was heavy, and I was like, oh my gosh, some of the things that.
Yeah. Yeah, unloading stuff, so.
Yeah,
Lighten up a little bit.
they were jumping equipment.
Yeah.
I had some faxes on us, some LR, and these LR was the big thing.
Yeah. Oh, yeah. Yeah, I remember rolling down the road with it.
Yeah.
On the wheels, so we could get a little bit of lift.
No, well, here we go, here we go.
Okay.
Yeah, to see back then, Hermes was a little bit nicer choppers, I think. We had the Bell 206 and the 223. Because it was the 222 up
We had to go behind Tim, well, up behind Guardsman's Pass and rescue them. They had the 206 up there.
Was it 206?
They landed,
Couldn't get off.
and I mean, they were way far away from any roads or anything. So we filled up, picked up the road,
Messes up and
got them out of there. And then the pilot had enough. It was light enough.
Light
First
enough to
coffee.
get off.
Do you need a cup of coffee or a drink or anything?
Do you know what? I think I'm good.
Okay.
Thank you. All right. Have we got almost everyone back? Looks
almost
like?
we can start.
Enough.
Enough?
And we got all
Okay.
the important people back.
All right. So, when we think about the pathophysiology of shock, so in other words, what causes shock, right? It's these three things right here. Bleeding, respiratory failure, acute allergic reactions. These are some of the things that are the actual causes of shock, okay? And they are all directly linked to this A, B, and C that you see here. And I think you may have this same chart in your book. You have that? Okay. So, pump failure, when we think about pump failure, causes are heart attack, trauma to the heart, obstructive causes. What are some of the obstructive causes? Tamponade. Okay, pneumothorax, pulmonary emboli, those are all obstructive causes. So low fluid volume, okay, so causes are trauma to the vessels or tissues, fluid loss from the GI tract. I mean, do you think about that causing shock? They can, absolutely. So vomiting diarrhea can also lower the fluid component of the blood. All right, so it will cause a shift of that fluid out of the bloodstream into the cells. Poor vessel function causes are infection, drug overdose, narcotics, specifically spinal cord injuries, and anaphylaxis all can affect the vessel function. So again, these are some of the main causes of shock. So you can just expect. So I always tell my patients, when my patients come into the emergency room, this is what I always tell them. I says, you're always guilty of the worst possible case scenarios until you prove yourself innocent. Okay, so it's different in the court of law. In other words, the chest pain patient is guilty of having a heart attack until you know they're not. Okay, the trauma patient is guilty of going into shock until you see that they're not, or you're preventing them from doing so. The neurological impaired patient, the Bell's palsy patient is guilty of having a stroke until you prove that it's not. Okay, that you prove that it's Bell's palsy or whatever. So any kind of problem, if whatever problem they're complaining of, they're guilty of the worst possible thing that could be going on until you prove that they're not guilty. Okay, so expect shock if the patient has multiple severe fractures, especially if we're talking long bone fractures. Okay, can you go into shock from a pelvic fracture or a femur fracture? You bet. Okay, you can lose a lot of blood from those fractures. Okay, so yes, if they have multiple or severe fractures. Abdominal or chest injury. Okay, can rib fractures kill you? Right. It's not the rib fracture that'll kill you, it is the underlying injury that will. Okay? So whenever you're doing your assessment, you're looking for what lies beneath. Okay? So as you're looking at abdominal and chest trauma, If you see a bruise or if you have pain here, they are guilty of what until proven innocent? Ruptured spleen. Okay? If they have bruising or pain here, they're guilty of what until proven innocent? Liver laceration. If they have pain here, they're guilty of what until proven innocent? Injuries to the kidneys. Can kidneys bleed out? You bet. Okay? So as you're doing your assessment, abdominal or chest injury, you're thinking about what lies beneath. That's important. And they're guilty of that specific thing being innocent till you know they're not. And the only way they can be proven innocent is what? ER, X-ray, CT, proving that it's okay. Severe infection. Okay, if you've got someone that has a severe infection, you go to the little 90-year-old lady's house, okay, and she is unresponsive. She's got a blood pressure of 80/40. She has a heart rate of 120, and she has a temperature of 39.2. Okay, what's wrong with her? Something's wrong with her. But what are you seeing? Septic shock. Okay. Turns out, we check her urine. She's got a massive urinary tract infection. She's got kidney involvement, so she is in shock from a urinary tract infection. Have you ever thought about urinary tract infections being able to cause septic shock? Absolutely. Okay, absolutely. So again, it's putting all those pieces of the puzzle together to figure out what's wrong. So the 90-year-old lady with a blood pressure of 80/30, a heart rate of 120. So she's got shocky vital signs, right? You have a temp of 39.3. That's the trigger right there. Okay, is the pump okay? Probably. She's 93, so it may or may not be. Okay. Is the respiratory okay? Her stats are 96%. Her breath sounds are clear. Okay, so is the respiratory okay?
Sure.
Is her blood okay? She's not bleeding out anywhere that you know of. You don't find any evidence of internal bleeding. Volume-wise, she may be low because she's tachypnea. Did you know you can lose a lot of volume through rapid respirations? Not only do you breathe off CO2, you also breathe off moisture. I mean, you know that just by breathing onto a mirror, right? What does it do? Fog it up. You're exhaling moisture. Okay? You ever thought about your respiratory rate contributing to your losing volume? It can. Okay? A temp of 39.3. What does that tell you? Do you remember your normal temperatures in Celsius?
Nope.
that would be why I'm getting a deer in the headlights look. Okay, 37's normal. Okay, 39.3 is probably about 102 point something. Okay, so in the medical world, we measure in Celsius. Okay, so we measure it in Celsius. So 37 is normal. So a temp of 39.3, she's got fever. Okay, so that's the trigger that you go, okay. Pump may or may not be okay. Blood most likely is okay. Could be a little bit low. So in a sepsis situation, what's one of my main problems? In a septic environment, I'm oftentimes acidotic. When I'm acidotic, I know what happens to my vessels. Okay? So I've got a volume problem related to my vessels. Okay, so I'm in a septic shock.
Did you say that in sepsis that there's that third spacing can occur?
And third spacing, yep.
Why is that?
So what happens in this acidotic state too, the cell membrane starts to break down. And with the cell membrane breaking down, the fluid leaks out of the cell into the extracellular tissues.
Gotcha.
So, yeah. Major heart attack. Okay, you're going on the chest pain patient. You've got a patient who's had chest pain for the last 3 days, and he's been taking Pepto-Bismol like crazy. Okay, because it's got to be indigestion. Now you get there, and what you see is he's pale, cold, clammy. He's downright gray. okay? You put him on and his oxygen level is 86% on room air, his blood pressure is 90/40. Hard to tell what his heart rate is because he's got an irregular rhythm, he's throwing PVCs like crazy, may or may not be at a normal rate, but his blood pressure is low. So what's the problem here? Is my blood okay?
No, it's not moving okay. Volume's fine, but movement.
So the blood itself is okay, right? Is my respiratory okay? It's not adequate, but why? Because my pump's failing. Okay, my pump is failing. And because my pump is failing, okay, it's not able to move through the lungs as well as it should, to pick up the oxygen like it should. I've got poor perfusion because my pump is failing. I am going into a shock because of pump failure. Okay? Anaphylaxis, okay? Allergic reaction. Little Johnny just got stung by a bee. Okay? And so we have this massive histamine release. All right? We start swelling up. The cells start to break down because of this massive histamine release. And it starts leaking fluid out into the tissues. The bronchi, okay, start to really, really constrict. Okay? And so what's the problem here? We've got a couple things going on, right? So we have cells that are probably leaking fluid out into the tissues, so we could have a little bit of a volume area there. But we'll oftentimes see the same thing as like, we may get a massive vasodilation as well in the anaphylaxis. So shock may be the result of a variety of causes. Hypovolemic, what does hypovolemic translate into? Low volume, okay? It doesn't say low blood, right? It's not saying low blood. That would it would be bloodhemia. Okay, so it's hypovolemia, low volume. So low volume can be anything. So a lot of times we have a tendency to associate it with blood. But hypovolemic shock is due to inadequate blood volume or just volume period, because as you lose volume elsewhere, okay, it will take fluid out of the blood volume, okay, to try to replace. It can be hemorrhagic and non-hemorrhagic causes of hypovolemic shock. So hemorrhagic shock would be what then? Trauma. You're bleeding out. Okay, whether it's internal or external. You could have hemorrhagic shock related to a ruptured spleen that's bleeding internally. You can have external hemorrhagic shock related to the lacerated artery in the groin. The patient that I remember going on where he had a grinding blade that shattered and went right into his groin. And he was bleeding out through his femoral artery. It was one of those patients that you're bleeding out LR by the time you get to the, LR was the fluid back then. By the time you get to the ER, that's what they were bleeding, was LR. So, so that is hemorrhagic. Non-hemorrhagic shock occurs when fluid loss is contained within the body. Give me some examples of a non-hemorrhagic shock.
Dehydration.
Dehydration causes would be
Lack of fluid.
diarrhea, vomiting. What about burns? Okay. If you touch the stove and you get a bad burn on your finger, what is that blister full of? Fluid from the cells that have been damaged and leaked out into the tissues. So that's just that one little tiny area. Can you imagine a large area and all that fluid? Is that a shift of volume from where it's supposed to be to where it's not supposed to be? So you bet that's a non-hemorrhagic shock where the fluid loss is contained within the body. So abnormal losses of fluids and electrolytes, dehydration, can occur through gastrointestinal losses. So we'll just review this again. Vomiting and diarrhea. Increased and excessive sweating, okay, can lead to dehydration. Internal losses, peritonitis, pancreatitis, and ileus. Again, these are all things that can leak fluid into areas areas where it's not supposed to be. Plasma losses from burns, drains, and granulating wounds. Other causes include ascites. What is ascites? Any ideas?
Like a fluid that in the abdomen from the liver.
Yeah, who usually gets ascites? Liver failure patients, alcoholics, yeah, alcoholics definitely have a problem with ascites. But it's anyone who has, but even advanced stages of hepatitis, liver cancer, anything involving the liver oftentimes they'll result in ascites, and they can have liters of fluid building up in their abdomen. How does that do as far as circulation goes and whatnot when you've got all this pressure from this fluid building up in the abdomen? So not only do you have all this fluid where it's not supposed to be, you've also got pressure from that fluid impeding circulation as well. Okay. Diabetes insipidus. Okay. Diabetics, when they get into trouble, can they pee lots and lots and lots? They sometimes can. Okay. Sometimes they can dump tons of fluid where they're peeing just straight fluid, and they actually show signs of shock from peeing out so much, because things just aren't, the whole physiology behind what's going just isn't working right. Okay, they're losing volume and they shouldn't be. Osmotic diuresis secondary to hyperosmolar states. Okay, what's an hyperosmolar state?
It's like too much concentration of something.
Of
in the
something,
fluid.
yeah, that's just causing, again, a shift of fluids. We need to have all the correct amount of electrolytes in our body. If you have hypernatremia or hyponatremia, it can cause shifts of fluids where they're not supposed to be. Okay. So the earliest signs of shock, and again, as we go through this, I want you to think about the sympathetic response and the body's mechanisms that occur to keep itself intact. Okay. Earliest signs of shock are restlessness and anxiety. Okay. Does that mean they're going into shock? I mean, like if you were just in a car accident and you have a fractured wrist and you've got that usual skid mark of the face from the airbag, right? Okay. Is that person going to be restless and anxious? Yes. Have you had enough experience to know a normal reaction versus kind of an abnormal reaction? Some of you can say, yeah, I have. I've been on enough instances where I understand a normal reaction versus an abnormal reaction. But a normal reaction would be, they may be crying or whatnot. But have you seen someone whose response was a little bit outside of what you would consider normal? Sometimes it's just coping mechanisms, and I think we've kind of moved into this generation of where people maybe don't have quite the coping skills that I've seen in the past. I don't know if some of you have noticed that. There's also cultural differences, okay, where maybe some cultures are a little bit express anxiety in different ways than others. It's really interesting. Vietnamese, for example, if you go on someone who's been injured and they are a Vietnamese response, how many of you have seen Vietnamese people really, really cry? A lot of times they're very stoic, and what they have a tendency to do is smile. That's their response when they're anxious. So a lot of it is learning the cultural differences to assess whether or not their anxiety is a normal level or not. Okay? So restlessness and anxiety, the patient may be thirsty. Okay, and that's part of the sympathetic response. They may be just because of cholinergic responses and whatnot, it makes them thirsty. Pale, cold, clammy skin. What's that?
Vasoconstriction.
That's the sympathetic nervous system kicking in, right? Causing some vasoconstriction. They're already starting to shunt. Okay, so should that be kind of an initial? So these first are like, okay, they're anxious. Check. Note. I'm just making a note of that. Okay. All right, they're complaining of being super thirsty. Okay. Check. I also gave them morphine, so, or the paramedics gave them morphine, so they could also be thirsty because morphine makes you really thirsty. But Okay, check. I know that that could be a sign and symptom of the early stages of shock. Pale, cold, clammy skin, all right? That's not one of those things that you go, okay, so that could or could be a symptom of shock. You see pale, cool, clammy skin, you have started. Okay, you have started down that pathway. The sympathetic nervous system has been stimulated and they are starting to shunt. Okay, so anyone you see pale, cool, and clammy, they have had a trigger of that sympathetic nervous system and they've started on that cascade. All right, so you should be looking at that and going, okay, they're pale, they're cool, they're clammy. All right, let's get our 2 large bore IVs going and let's think about getting on our way. Okay, that should be one of those that it's like, okay, yeah, we've started on our cascade. We've got a rapid heart rate. Okay, so I've got a fast heart rate. What's the difference between a rapid heart rate from shock versus a rapid heart rate from anxiety?
Strength.
Yeah, a lot of times it's not just the rate, it's the character. Okay, a rapid bounding pulse. Does that person have good perfusion?
Yes.
Yeah, you've got a heart rate that's just boom, boom, boom. How are you anticipating in their mind their stroke volume is? How's their cardiac output?
Solid.
It's solid. Okay? How many of you have felt the pulse and it felt just like this little trickle underneath there? Okay, what's that called? Okay, you've got a rapid, thready pulse. How does that change your sense of urgency? If it's not changing your sense of urgency, it should. Okay? So, because what's my perfusion level? What's my cardiac output? What's my stroke volume? If I've got a rapid, thready pulse, my stroke volume, my cardiac output is not what it should be. Yeah, but your blood pressure is 120/80. Okay? Does that give you more of a comfort level?
You might go get on top of it.
In other words, you haven't hit the end of your cascade yet, but you're well on your way. Okay? So a rapid bounding pulse is someone who is anxious. Okay? This is someone who is anxious but has not gotten to the point where their cardiac output's been affected. That rapid bounding pulse is probably because they're anxious and they may or may not be on that cascade. Now, rapid bounding pulse with pale, cool, clammy skin. Okay, take note. Okay, that pale, cool, clammy skin, take note. Okay, but a rapid, thready pulse, you are this far from being at the end of your cascade. Okay, because your cardiac output is already being affected because you can barely feel that pulse. What if you can't palpate a pulse, a radial pulse? How high does your radial pulse need to be for you to be able to palpate it? How high does your blood pressure need to be for you to 80 to 90? Okay, if you can't feel a radial pulse, that's why blood pressure, do you know what I mean? Blood pressure initially in the shocky patient, are we worried about getting a blood pressure right away? Now, what's our most important vital signs? Our respiratory rate and our radial pulse. And not just the rate, okay? It is not just a number. It is a character. Okay, it is a character of that pulse. As bleeding or fluid losses continues, that is when you're going to see that blood pressure fall. So if you get to the scene and you already have someone with a low blood pressure, you're at the end of the cascade. All right, you're already behind the 8 ball. Now, can you still fix that? Yes, you can. But what may be your biggest priority? I mean, you know in your mind, okay, I've got to get on oxygen. I need to get my 2 large bore IVs and I need to give them a fluid bolus. What is also one of your main priorities? Hospital transport. Okay, they need to die on the next person. Okay, transport. Do not delay your transport to put on a splint, even though you've got this wickedly deformed finger. Okay, that can be done in room. Okay, do not delay transport. All right, if you've got someone who already has a low blood pressure, you are running out of time. Okay, So, let's talk about the different type, so we've kind of talked about hypovolemic shock, etc. Let's talk about cardiogenic shock, okay? So cardiogenic shock is caused by an inadequate function of the heart, okay? The pump is failing, all right? Why is the pump failing? This is what we need to figure out. It develops when the heart cannot maintain sufficient output. As the afterload increases, cardiac output decreases, okay? So, why is our pump failing? This is what we need to determine. Is the patient have an MI? Did the patient have trauma to the heart? Do we have a cardiac tamponade? Do we have a cardiac contusion? Do we have, can a pulmonary embolism cause cardiogenic shock? Okay, think about a PE. How can a PE affect the heart? PE is where? In the lungs. Okay, you got a big old clot in the lung. Okay, so as you think about the heart, all right, we've got our heart here. Okay, we've got our 4 chambers. Okay, we've got our blood coming in to our heart. Okay, from our superior and inferior vena cava, and it goes into our right atrium. Okay, it goes through our valves into our right ventricle. From the right ventricle, where does it go? Okay, it goes out to the lungs. So here we've got our lungs out here. Okay, so I'm a really good artist. Okay, so here we've got a big clot. Okay, so this blood's trying to pump through the thing, and it hits this, and it is obstructing the circulation here. So where all this blood being pumped into this lung, where is it going to start to go? It's going to start to back up. Okay, and it's going to start backing up into here. All right, so now it just can't get it out. It's starting to back up. So this blood in here is going to back up where? It's going to start backing up into here, okay? And so pretty soon this starts to fill up. And so where is this going to start to back up? Okay. Will this cause the pump to start to fill? Absolutely. So can you see how something out here in the lung can cause a pump failure and cause a cardiogenic shock? And the ability of that heart, because what is the definition of shock? A collapse of the cardiovascular system. And the cardiovascular system is made up of what? The heart and the lungs. Whew, is it all just kind of like, oh, I get this, right? Okay. So obstructive shock. Okay, so this is also obstructive shock and cardiogenic shock are very, very similar. Okay, kind of go hand in hand. Results when conditions that cause mechanical obstruction of the cardiac muscle also affect pump function. So cardiac tamponade is considered an obstructive type shock. Okay, cardiac tamponade when blood leaks into the pericardium. All right, so you've got your heart here again. So here we've got our heart. Okay, here we've got our pericardial sac around our heart. This person just got stabbed, or they just had it in a bad car accident and a rib has gone through and penetrated the heart muscle. Okay, the heart has its own circulation, right? The heart muscle, and does it bleed? Yep, and so where's it going to bleed out into? Into this pericardial space, okay? So this pericardial space is starting to fill up. And so as this pericardial space starts to fill up, all right, what's it going to do? Compress the pump. Okay, it's going to compress the pump, right? And so what are you going to see in your vital signs? What's your blood pressure going to do?
Drop.
Think about the physiology of what's going on. Do you remember when we talked about our pulse pressures? We have our systolic pressure, which is when the heart's pumping. We have our diastolic pressure, which is when it's at rest.
Narrow?
Yes. Our pulse pressures are going to start to do this. Okay, they're going to start to narrow because that heart is not able to contract. Okay? That leads to an obstructive shock. Now, can you call it a cardiogenic shock? Yes, because the pump is failing, right? But it's more correctly called an obstructive shock. Okay, so tension pneumothorax. Okay, what's a tension pneumothorax?
For the air of the lung leaks into the cavity and compresses the lung.
Right, so here we have our lungs, okay? So we have our lungs here. All right, our heart's sitting right here, okay, in the chest. Okay, so here's our stab wound, all right? And we have our pericardial sac, or I mean our pleural sac around the lungs, okay? We get stabbed here in the lung. And what does air want to always do?
The lowest pressure.
Equalize, right? It always wants to equalize. So you take a breath in, and where is that air going to want to do? Equalize here. So your air is going to start to leak out into that pleural sac. So now this starts to fill up. So what does it do to this lung? It starts making that lung smaller. Okay, so we've got all this air now that's just leaking out into the chest cavity. Okay, and so the lung is getting smaller and smaller, and all this pressure is going to do what? Put pressure on the heart, which is then going to shift everything over. So you may have heard, oh yeah, they have a shifted mediastinum or widened mediastinum. It's because everything's been moved over, because this air is now taking up all of the space. Do you see why this is called an obstructive shock? Think about the ability of that lung to oxygenate when it's being pushed and made smaller and shoved over. So with a simple pneumothorax, that one lung is affected. Can you live with one lung? Yep. With a simple pneumothorax, you may not even register that anything is wrong. But when you get to a tension pneumothorax, that's when things have been pushed onto the heart. And think about the heart now being pushed over against this other lung. Okay, so this lung's completely collapsed. It's like out of the ballgame. Okay, it's not even ventilating anymore. And now it's shifting against the whole cardiovascular, the whole cardiac system. Okay, so obstruction, does that make sense? Yeah, we've definitely got obstruction going on. Pulmonary embolism, and we talked about that one, how that is an obstructive shock that basically starts to fill up. And again, cardiogenic, it's affecting the heart. So cardiogenic is usually, you know, the pump is failing, MI, whatnot. Then we have the obstructive shock that is cardiac tamponade, tension pneumothorax, or pulmonary embolism. Let's talk about distributed shock, okay? This is when things aren't being distributed right. The fluid just isn't where it's supposed to be, okay? It results when there is a widespread dilation of small arterioles and small venules. And it can also be caused by toxins damaging the vessel walls from sepsis. And so we kind of touched on this already a little bit. Distributive, when the vessels are this big, and you've only got this much volume and the vessels are supposed to be this big, obviously you have a distributive type shock where you've got low blood pressure as a result of the vessels not being the appropriate size for the amount of volume that's circulated, okay? Or in the cases of septic shock, where you've got vessels that are leaking fluid out to where the fluid is not supposed to be. Okay? So is that fluid being distributed correctly? No, it's not. So you have a distributive shock. So in your tests, as you're thinking about, okay, what kind of shock is this? Think about the distribution. Is the fluid being distributed correctly? And no, it's not. And it's usually a result of septic shock or widespread dilation. Neurogenic shock is similar, but because of a different cause. Okay? So when you're thinking of, okay, you know, I've got a distributed shock, but what's causing it? Sepsis versus a neurological problem, okay? Neurogenic shock is due to damage of the nervous system. In other words, the information is unable to get from here to here to tell the vessels what to do, okay? Is my blood volume fine? I mean, I haven't lost any blood. I'm not septic, so it's not leaking out where it's not supposed to be. Okay? It's just the signal from here to here isn't getting there because I have a disruption in that signal right here. Okay? The pathway has been cut off. The communication has been cut off. Okay? So damage to the nervous system that controls the size and muscular tone of the blood vessels. All vessels below the level of the spinal injury dilate widely increasing size and capacity of the vascular system. Now, I want you to think about the signs and symptoms that you may see in someone with neurogenic shock. How are they different? Does the brain know that anything is wrong?
No, there's no communication.
No, the brain may not know that anything is wrong, right? So is the brain going to stimulate the sympathetic nervous system? No. So are you going to necessarily have pale, cold, clammy skin? No. As a matter of fact, if you've got a disruption in the blood vessels below the level of the spinal and they dilate, what might the difference be between here and the level of the spinal injury and below? What are you going to see? It may even be a little bit flushed and warm. Why? Because those vessels have dilated. Okay? But what's your blood pressure going to be?
It's gonna be low.
It's going to be low. Why?
There's not enough volume to treat that pressure in the.
Because all the volume is in the vessels. Okay? It's not getting to the organs. So it eventually will trigger that cascade in lower areas, but you're not going to have that initial trigger of the sympathetic nervous system because the communication's just been cut off. What's really, really interesting in taking care of a neurogenic shock is that, so volume replacement, will volume replacement help? It may help a little bit, but what is going to be the biggest benefit to treat a neurogenic shock patient? Vasoconstrictors. Okay, medications that will cause that vessel to constrict. And I kid you not, a neurological shock patient, we are dialing vasopressors up and down, Their blood pressures sometimes are all over the place. Because it's like it gets a little hint of something and then no, and then now and no, and the vessels are back and forth, back and forth. So neurogenic shock patients can be really, really tricky to take care of, to try to maintain. And what are we shooting for? When we're controlling vasopressors, when we're dialing vasopressors, what are we shooting for? What number am I watching?
Radial pulse.
My mean arterial pressure. Because what's my pulse rate most likely going to be? It could be normal. It could be normal. I could have a little bit of an elevation in my pulse rate. If my organs are starting to be affected, okay, then the organs are going to say, brain, something's going on here, and it may trigger some of that sympathetic, but initially it may not, until the perfusion from these dilated vessels that just aren't getting the message, okay, until those start to affect everything else, the brain may not know what's going on exactly. And so you may not have the exact signs and symptoms as a regular shock in the neurogenic shock. So how do you diagnose this? What's my mechanism of injury? What's my index of suspicion for a spinal cord injury? Is it consistent with that I could be dealing with a neurogenic shock? On all of these, it's like, what's my mechanism? What's my mechanism? What's causing this? The little 9-year-old lady with the temp of 39, what's my mechanism? Sepsis, okay? The traumatic injury in the car, what's my mechanism? Well, I have a steering wheel that's been collapsed into the dashboard. I have that nice little starred thing, you know, the windshield that bulges out with the cute little tuft of hair. We've all seen that hanging right from the thing. Okay, what's my mechanism? Okay, well, you know, it could be, I mean, do I have a spinal cord injury? So could it be a possibility of a couple things going on? Absolutely. Absolutely. Okay, so again, what's my mechanism? What caused this? Anaphylactic shock. Let's talk about anaphylactic shock. It occurs when a person reacts violently to a substance to which he or she has been sensitized. Any of you have allergies to food, medicines? I happen to be deathly allergic to grapes, of all things. Okay? My airway swells shut. My eyes swell shut. Okay? If I eat grapes. So I have, you know, I have to be really, really careful. I read the ingredients on everything because they hide white grape juice in orange mango, you know, juice. So it results in a widespread vascular dilation, okay, increased permeability, meaning that the fluid leaks out of the cells into the tissues. That's why people swell up, okay, and bronchial constriction. So what is all at play in anaphylaxis? How's my pump? My pump's probably okay, right? My pump is probably okay. But how are my vessels?
Blood pressure.
My widespread vasodilation. So are my vessels an issue here? Yep. How is my fluid? How's my volume level?
Probably low.
Yeah, I'm getting a shift here. So vascular dilation, so my vessels, boom. In my perfusion triangle, my vessels are at risk. Okay, my vessels are dilating, that's a problem. In my blood cells are fine. I'm not losing blood, but where's my fluid going? It's going out. Okay, I've got increased cellular permeability, so therefore my volume is going to be lowering because it's going to be going out in other areas instead of staying in the vascular system. Okay, so I've got two potential problems with anaphylaxis. So any questions on anaphylactic shock? Okay, so two different problems. Our pump's okay, but our volume is at risk, and our vessels definitely are at risk, okay? Psychogenic shock. What is psychogenic shock? Okay? How many of you have ever gotten lightheaded or felt like you were going to pass out when you saw something? Okay, you see something very traumatic. Or you've got someone, you know, you're starting an IV on someone and they start to get, oh, I'm a little bit dizzy. Okay, I don't feel well. That is an example of a psychogenic shock reaction. Have you ever seen anyone faint as a result of seeing or hearing something? Okay, well, what the heck? This person just went down. Okay, it occurs when patient has a sudden reaction of the nervous system that produces temporary generalized vascular dilation resulting in fainting. Okay, it is a trigger of the nervous system as a result of what they've seen, heard, experienced that causes a massive vasodilation.
It says temporary. How temporary? As soon as they pass out, does it go back to normal?
It does. So what happens is that, okay, and does fainting ever occur when you're lying down? No. Not this kind of fainting. Fainting does not occur when people are lying down. It's when they're in an upright position. And I want you to think about the physiology behind it. You are in an upright position, okay? You're doing just fine. You just witnessed something horrific, and your brain registers this and like sends this response, and your vessels suddenly dilate. Okay, where does all your blood go? Down here. Okay, how's the perfusion to your brain? It's not good. Okay, it's not good. Your brain is suddenly not getting the blood and oxygen it needs. So what does it do? It shuts off. Okay, it doesn't have the blood and oxygen it needs to keep functioning. So boom, down you go. You are now in what position? all this fluid now is able to get where a little more easily? Back to the brain. Okay, because it's no longer having to go uphill with all of these vessels that have just dilated and dumped all this blood down here. Okay, now they go into a supine position, the blood now gets to the brain, and the person does what? They wake up. Okay, that is the physiology of psychogenic shock. Okay, was the pump okay? The blood volume okay? It just wasn't enough because the vessels suddenly became the problem. All right, so it causes a massive vasodilation. Blood rushes down. If you know, it's like sometimes when you say, "Oh, the blood's rushed to my head," or you get lightheaded standing up. Think about orthostatic vital signs. When someone is orthostatic, okay, is it because they do not have enough perfusion to their brain when they sit up or stand up? And the symptom and the cause of orthostatic vital signs are what? Low volume. Okay, someone is orthostatic when they have low volume. Usually they're dehydrated. Okay, someone may be orthostatic after being sick for a week. Okay, you go to the 28-year-old girl who's had the flu. She's had nausea, vomiting, and diarrhea for the last 3 days. She's got a resting heart rate of about 112. Okay, you go to stand her up to go walk on the gurney, and she does this. Right?
What's orthostatic?
Orthostatic. So orthostatic hypotension is when someone experiences just what I've been describing. In other words, they do not have the ability to get blood and oxygen to the brain because of low volume. Okay? So that is the physiology behind psychogenic shock. So the progression of shock, okay, it occurs in 2 successive stages. Before I kind of talked about, okay, they're compensated. There is a compensated shock and a decompensating shock. So compensated shock, all that really means, like, to simplify all of this, someone who is in compensated shock means they have all the signs and symptoms of shock, except for they have a normal blood pressure. If I want to just simplify it, their blood pressure is fine. But why is their blood pressure fine? Because of all the mechanisms that have gone on to maintain that perfusion. The activation of the sympathetic nervous system, the shunting, the autotransfusion that's going on. In other words, and we talked about it, yeah, they have a heart rate of 120, but their blood pressure is 120/80. So they can't be in shock. Yes, they can. They are in what? Compensated shock. In other words, their blood pressure is still okay because they're still perfusing because of the backup mechanisms. So compensated shock, early stage of shock while the body can still compensate for the blood loss. Okay? Chemical mediators are released by the autonomic nervous system. Okay, right? We've got the antidiuretic hormone that's being released from the pituitary gland that's telling the kidneys to quit producing much urine because we need that volume to stay in the bloodstream. We've told the spleen, hey spleen, you need to release a little bit of those red blood cells back in the bloodstream. We've kicked out our little bit of epinephrine, our norepinephrine, and keeping our vessels constricted. We've shunted, right? And we've done all of this to maintain our blood pressure. And we have compensated, okay? So our pulse pressures equals our systolic minus our diastolic pressure. So again, we've got a normal, good pulse pressure, okay? So we're compensating. Decompensating, all right? This is when we run out, we've gone down that cascade, all of our backup mechanisms are exhausted, and we're starting to lose our blood pressure. That is a decompensated shock. So our goal as an advanced EMT is to try to avoid getting to the decompensated phase. Okay, to recognize compensated shock, recognize the early signs and symptoms of shock, and to prevent getting to that decompensated phase. Okay, late stage of shock when blood pressure is falling, the blood volume decreases more than 30%. Do you remember how I said those symptoms or those systems that cascade can accommodate for up to a 25% blood loss? Okay, that's pretty significant. Okay, that you can lose up to almost 25% of your blood volume and still be compensated. because of all those backup mechanisms, because I've shunted, because I've released my antidiuretic hormone, because my spleen has dumped fluid out, because of all these things going on, okay? But decompensated shock is when we've lost a significant amount of blood and we have run out of backup systems, okay? Your compensatory mechanisms begin to fail. So we go from compensated shock, where our blood pressure is normal, then we go to decompensated shock, where our blood pressure is now falling. So now we're seeing signs of the blood pressure failing, and then we progress on to what we call irreversible shock. And remember that drain that we talked about as we circle the drain? Okay, compensated shock, decompensated shock, irreversible shock. Okay, that's where we are in our drain. Shock that has progressed to a terminal stage. Arterial blood pressure is abnormally low. Okay, life-threatening reductions in cardiac output, blood pressure, and tissue perfusion. This person is done. All right, and the problem is we maybe have gotten people back from what we have considered an irreversible shock. But that just means they don't die on us right now. They die a week later from all of the other mechanisms that we talked about that it triggers. Okay, they go into the DIC. They go into rhabdomyolysis because the kidneys have totally shut down. They go to, and then they just die a week later. So even though they may not die on us right away, in this irreversible shock stage, that's when we see the patients die, maybe a week later from all of the complete organ failure that we talked about earlier. So let's talk about our patient assessment. Okay, we're going to do a patient assessment of this scene. Okay, so obviously, who's most important in this scenario? Me. Who's second most important?
Partner.
My partner. And who's third most important? Bystanders. And who's kind of right down on that pecking order? The patient. Does that seem right? Well, and you're thinking, I'm there to save the patient. No, first of all, you're there to save your own butt. Make sure you're not going to be a victim, and that your partner's not going to be a victim, and that some of these people who are watching this are not going to be victims. Okay, whatever has happened has already happened to the patient, right? And yes, our goal and our job is to fix and fix what's wrong with that patient. But again, we need to make sure that we're okay. So look for and address hazards, threats to the safety of crew, bystanders, and patient. More traumatic injuries make it less likely that the patient will be able to compensate. So as you do a survey, can you not get a pretty good feel for that patient the minute you lay your eyes on them? 30 seconds. Do you know what? Literally 30 seconds. You can look at them and so I may come in and look at the patient and I'll say, okay, normal or abnormal? Right? You can start right there. Normal or abnormal? They're crying. Is that okay? Yep. Breathing. They're screaming and crying. Is their breathing okay? From what I can initially see. Now, I can still have a problem, but for right now, they're screaming and crying. Breathing's okay. Circulation. What am I looking for in 30 seconds that tells me if their circulation is okay or not? Abnormal or abnormal? Normal or abnormal? Color. Very, very first thing. Color. Normal or abnormal? They're pale. Abnormal. Okay. How long does it take to check a pulse? Do I care initially what my pulse rate is? Okay. What can you feel in just seconds? Normal or abnormal? Is it fast or slow? Is it strong or is it weak? Okay. How long does it take to do that assessment? Seconds. Okay. Seconds. So in your primary survey, perform a rapid full body scan of the patient, and that's all you're doing is you're coming and you're looking at that patient, normal, abnormal. Okay, and you're taking in things around you, right? You're immediately registering little things around you. I mean, when you walk up to a car, isn't the first thing you look at the mechanism of the damage to the car, right? that sets your initial sense of urgency. Does it not? Okay? A little ding to the center. What's your sense of urgency? You know, you're thinking low speed. I mean, it starts right, does it not? We have a 1050 PI on I-15, northbound at 600 south. What's your sense of urgency? Okay, the first thing you think of is high speeds, okay? We have a 1050 PI located at 300 north, 200 west, okay? Residential area, chances are speeds are not as high, okay? So again, you get your sense of urgency right from the beginning, right? From your dispatch information. So you perform your full body scan of the patient and you're taking the little notes, right? Of like, lots of damage, no damage. What's my appropriate sense of urgency as I'm approaching this patient? You walk up to the patient and you look at the patient and you think your initial scan is normal, but out of your periphery you're looking at the steering wheel and the steering wheel is completely collapsed. Okay? What's the first thing you're thinking in your head? Okay, they may be normal now, but are they, what's my chances that they're going to stay normal?
Yeah.
Right? High mechanism. So all of these things come into play. You're using your nose, okay? Do I smell alcohol? Do I smell ketones? Do I smell, all of these senses are coming in. You're coming in and you're, you know, hey, I'm so-and-so. I'm going to take care of you. How are you doing today? Okay? What am I doing? Okay? I'm feeling all sorts of things. What's his temperature? What's his pulse? What's his rate? Fast or slow? Thready, bounding. Okay? How long did that take me as I scanned? Okay? Again, seconds. Identify and manage life-threatening concerns. You know, we've been taught ovulation. In a trauma patient, there's actually a little bit more of a push for CAB rather than ABC. Okay, what would CAB be? Circulation, airway breathing. Okay, because we were finding that our patients were bleeding out. Okay, while we were taking care of and trying to manage their airway. And so if you think more in the CAB approach, okay, you walk up, full body scan. How long does it take to grab your partner and say, hey, get some pressure on that? How are you breathing? How's your circulation? And do a quick scan again. But you can usually identify right away if someone's got some significant bleeding, right? So quickly assess, identify and manage life-threatening concerns, which usually right off the bat is, am I bleeding out somewhere if it's a trauma patient, okay? Quickly assess the patient's breathing, okay? Normal or abnormal? If it's abnormal, what's abnormal about it? Is it obstructed? Do I have blood? Do I need dissection? Okay? Can you fix some of these things right away? How long does it take in an unconscious patient to open their airway? Seconds. Okay? Jaw thrust. Assess the patient's circulatory status. How long does it take to do that? Again, seconds. What's their color? What's their pulse? Fast, slow, thready, bounding. This is a quick assessment. And again, your primary survey is to help you identify the appropriate sense of urgency. Okay? And that is a big part of your job. Again, it's seeing that train coming before it hits you. Develop the appropriate sense of urgency. Okay, if the patient shows signs of hypoperfusion, gain IV access, treat aggressively, and provide rapid transport. Okay, do not get distracted by the grotesque injuries. What do I mean by that? Okay, you've got this leg that is wrapped up around their ear. Okay, and you walk up and you go, that ain't right. Okay, normal or abnormal? Abnormal. Okay, but what is your concern? CAB. Okay, control any bleeding, airway breathing, and then fix any circulatory problems because this is the shock lecture, right? We want to recognize our early signs and symptoms of shock and prevent them from, we want to keep them in the compensated shock. We don't want to allow them to get to the decompensated shock and eventually to the irreversible shock. Okay, our goal is to keep them in that compensated shock thing. Okay, just keep them in that area. So, treat aggressively. Do all shock patients get IVs?
Yes.
Yes, do this. Do this, yes. And is it a really, really good idea to get 2 IVs? Do this. Even if it's, what if it's just anaphylactic shock? Do this. Yes, 2 IVs. Because can they have a big volume problem? Yes. What if it's just a neurogenic shock? They just have an isolated spinal cord injury. They're not bleeding out anywhere. Is it still a good idea to try to get 2 IVs if you can? Okay. Now, does this mean you're flooding them with fluid?
No.
No. No. But do you have that option if you need to? Right. Okay. History taking. History taking is so important, okay? When I teach the trauma nursing core classes, we expand our alphabet. So as EMTs, and even when I teach paramedic school, I expand their alphabet. We have our ABCs or our CABs, okay? In trauma nursing core and stuff like that, we extend it all the way to I. Okay, A, airway, B, breathing, C, circulation, D, disability. Okay, E, environment. Okay, so we're going to undress them and then cover them back up. Okay, we want to keep them warm, and we're going to talk about that more in a minute. So A, B, C, D, E, F. What is F? Full set of vital signs. Okay, that's when we're going to start getting all of our stuff on. E, F, G. What's G? I'm going to put on all my gadgets. Okay, I'm going to get my monitors on. I'm going to get my pulse oximeter on. So I'm going to get my full set of vital signs, which includes a temperature. Go beyond heart rate, pulse, blood pressure. Get a temperature, because the temperature can help you identify other potential causes of shock, such as septic shock. Okay, A, B, C, D, F, G, H. Now I'm at history. History and head to toe, and they can be done at the same time. So, tell me what happened, right? We're a hands-on crew. How did this happen? And we can get a sample history. What does sample stand for? S. Signs and symptoms. A. Allergies. M. Medications. P. Past medical history. L. Last oral intake. E. Events leading up to the accident. Strong work. Very good. Okay, so determine the chief complaint. Find out what happened so that you can determine if you are seeing shocky vital signs, what's my cause? Is it cardiogenic? Is it obstructive? Is it distributive? Is it anaphylactic? Is it a septic shock? Is it, what's causing my shocky vital signs that I'm seeing, okay? Or my pale, cold, clammy skin. Obtain medical history. Be alert for injury-specific signs and symptoms. Okay, and again, that history can help you determine which type of shock you may be dealing with. Okay? Quickly obtain your sample history. And your medication, I'm on Eliquis. Now, I know you guys aren't pharmacists, but you know what? There are some meds that you just are going to have to learn what they are. What is Eliquis? It's a blood thinner. Okay, and it's replacing Coumadin. Is that a significant finding for someone who's had a traumatic injury? It is. Do you know what? Someone who's on Eliquis or Coumadin can make the difference of that patient being classified as a trauma at our facility. A ground level fall in an 82-year-old who's not on blood thinners may just be a regular patient. A ground level fall on an 82-year-old who is on Coumadin could be classified as a trauma too. So that one little bit of information, okay, can make the difference of whether they're called a trauma or not. Right? So it's very important. Okay, your secondary assessment, all right? So we are getting into our secondary, so our primary assessment, right? Sizing up the scene, we're sizing up the patient, normal or abnormal, and we're doing our CABs, okay? And we're getting our full set of vital signs, getting all of our gadgets on, and we're getting our history, and we're doing our head to toe. Now we're starting into our head to toe, our primary assessment, is our secondary assessment. First of all, you're going to repeat your primary survey. Okay, so you're going to start right at the beginning again. Okay, did anything change? Because can things change pretty rapidly for a patient? Absolutely. Things can change so fast. So we're going to quickly start again, okay, and do our quick primary survey again. And then you're going to start with your full body exam. Obtain and complete your baseline vital signs. Use your monitoring devices to quantify the patient's oxygenation and circulatory status. But can you see how this can all be kind of incorporated and done all at once? If you are not a good multitasker, you need to learn to become one. All right? So you need to learn to become a good multitasker and talk and assess and do all at the same time. All right? Where you're talking, you're assessing. I mean, we are a hands-on crew, right? If you don't like to touch people, you maybe want to consider going into something else, because this is a touchy-feely job. Okay? So you've got a hands-on, you've got to assess. So in your secondary assessment, your primary assessment is where you're going to establish if you need to scoop and run. Okay? And if you're seeing those signs, and you're getting vital signs and you're seeing a decompensated shock already, that's when you're getting on your way. And like I said, you never, ever, ever delay transport to splint a leg or to splint an arm. All right? It just isn't that important. What's important is treating your patient, okay, as far as the perfusion. So reassessment, whenever you do any kind of intervention, all right, you need to see if it's made a difference. So in other words, you put your pulse oximeter, they have a pulse rate of 88, and you put them on oxygen. What do? You reassess, did this oxygen help? Okay? You have someone with a heart rate of 128 and kind of a thready pulse. You start a line and you give them the fluid bolus. What should you do?
Assess their pulse.
Did it make a difference? Yeah. My pulse rate's come from 128 down to about 104, and my character of my pulse rate has improved. Okay? Does that mean you're good? Nope. This is also a job of constant assessment and reassessment, assessment and reassessment, assessment and reassessment. Okay? And depending on how unstable that patient is, will determine on how quickly you're doing that process of assess, reassess, assess, reassess, assess, reassess. Assess, intervene, reassess, assess, intervene, reassess. I mean, it is just this constant thing. You are never just good. Okay? You never just put a patient on a monitor and see sinus rhythm and think, I'm good. Okay? Case in point, we were getting a transfer patient from Riverton Hospital. Paramedics were bringing a patient that they were externally pacing. Okay? So this was a patient who's going to be coming to our hospital to go to the cath lab to have a pacemaker put in. They come in through the door and the charge nurse goes, whoa, wait a minute. What are the vital signs? They said, well, we're pacing him. We've got a good sinus rhythm. This patient didn't have a pulse. Okay? Somewhere along the way, they lost the pulse. Can you pace a beautiful pulseless electrical activity? Yes, you can. They had a beautifully paced sinus rhythm on their monitor. So what was that paramedic team doing? They were treating their monitor. Who were they not treating? The patient. Okay? Treat the patient, not the monitor. Okay? Determine any effects of interventions performed and interventions needed. Okay? Do I need to do more? I gave them a 500 cc bolus. Do they need more? Yes, my pulse rate is still 128. My blood pressure is still maintaining, but my pulse is still thready. I'm going to give them another bolus. Okay? Focus on supporting the cardiovascular system. And the cardiovascular system is contained of what? The heart, the vessels, the lungs. Okay? We're supporting all of that. That's our focus. Patients in decompensated shock will need rapid interventions. Decompensated shock is what? you've got a lowering blood pressure. Okay, you've got a lowering blood pressure. And you think, well, how do I know if it's lowered or not? Some people have a normal blood pressure of like 90/60.
Gotta get initial set first, to see what's happening.
What if they normally have a low blood pressure of 90/60? How do I know my blood pressure's low?
You can ask them.
Look at your patient. Your patient's going to tell you, okay? A low blood pressure in conjunction with an elevated heart rate, a weak, thready pulse, pale, cool, clammy skin. Anyone who has a lower blood pressure, I don't care if they tell you their blood pressure is normally low or not. You need to consider that that blood pressure is decompensated if they've got all those other signs and symptoms with it. If they've got a weak, thready pulse, they've got cold, clammy skin, I don't care if that patient says, well, my blood pressure is normally pretty low. You need to be especially diligent. And say, well, we're just going to elevate it just a little bit. Let's give them some fluid. Okay? All right? Look at your patient. What is your patient showing you? What are they letting you know? Okay? So again, decompensated shock. In your treatment for decompensated shock, 2 large bore IVs, fluids in. Rapid transport. Okay? Get them to die on the, let them go into the irreversible shock on someone else. Okay? Treatment begins during the assessment process. Control all obvious external bleeding. And again, it's CAB. Okay? If you see that immediately, it takes 2 seconds to get some direct pressure applied. Place the patient in the position dictated by local protocol for shock patients. Provide warmth, gain IV access, and do we get 2 if we can? Do this? Yes. Okay. Why are we providing warmth? Why is that a big deal? Think about our physiology here. Why do we not, some patients we cool, right? We cool them on purpose. We're protecting the brain.
If they're shutting down peripherally, that lowers their ability for their body to automatically control its temperature, because you're not getting the kind of diffusion onto your skin.
And if you are cold and shivering, what does that do to your metabolic demands? Yes, it's requiring more energy. And do you need that person's energy and oxygen to be going to shivering muscles? No. Where do you want that to be? Going to the organs that need it. You want that oxygen there. So I don't know if any of you have been into the trauma rooms at IMC, but they are bloody hot. Okay, we keep them really warm, and trust me, I'm an over 50 female who has hot flashes, and when you're wearing lead and the trauma gown, which is supposed to be non-permeable, and you're in an 80+ degree room, it's not really comfortable. But you know what? Our focus is we want to keep our trauma patients warm. We don't want their energy to be expended on things that are not necessary. We want that energy and oxygen to be going to the organs that need it. Okay, so provide warmth. Gain the IV access. That's why it's important to give warm fluids. How many of your rigs carry warm fluids? So I know back when I was on the ambulance, do you know how we warmed our fluids? John Moore. We put them underneath the dash and turned on the heater. We kept a stash of IV fluids on the baseboards under the dash of the ambulance, right, John? That's how we warmed our fluids. Okay? Because can you imagine if you were to hang what temperature are fluids? Room temperature. Right. So let's say the outside temperature is 76 degrees. What temperature should that patient be? 98.6. Is that a little bit chilly for them? Do you think you're going to increase their metabolic demand if you give them chilled fluids, cool fluids? Yeah. That's why warm fluids. That's why we keep warm fluids in the trauma room. Okay. Our golden hour, first 60 minutes after injury. Okay. So that golden hour just kind of refers to is that this is when a lot of times this cascade of backup systems is going on. Okay, it's during that. But can it happen much more quickly than that? Yes. But that golden hour sometimes determines on whether or not that patient's going to hit that irreversible shock, on whether or not. That's why it's so important. Rapid transport, get them to the hospital. Provide your initial management for shock. Manage their airway. If they don't have a good airway, are you going to be having a good breathing effort and circulation? I mean, again, our support is to support the cardiovascular system, right? And so that's how involved, all right? So manage their airway. Administer supplemental oxygen. A lot of times we have in our mind, well, if they're above 90, we're good. But just know that on the traumas, we like them above 94. If they're below 94%, we give them oxygen. Okay, we like them now, do we need them at 100%? No, we don't. Okay, we don't. But if they're below 94%, we give them oxygen. So we like to shoot for 94. So in the world out there, you know, they may say above 90 is okay, but on a trauma patient, above 94 is kind of what we shoot for. So administer supplemental oxygen. Place the patient in a position of comfort. How might that differ? So you've got a trauma patient with hypovolemic shock. What is most likely going to be their position? In spinal precautions, right? It may not necessarily be the position of comfort, but that is the position you need to be in. In someone who has had an MI and you're treating possible cardiogenic shock, what is going to be their position?
Probably sitting up.
Sitting up. Absolutely, to help facilitate their breathing, etc. Anaphylactic shock. Okay, what's going to be their position? Yeah, they may even meet. Okay, so position of comfort. Obtain your vital signs. Obtain your IV or IO access for medication or fluid boluses. And again, maintain your body heat. IV therapy, all right? Your IV lines are inserted to provide. So why do we start IVs? Have access for what? Fluids? Medications? Okay, right here. A route for immediate replacement of fluid. Okay, that's going to be our main thing, right? In most of our shocks, is we need to get them fluid, all right? We need to give them something to pump. A route for potential replacement in patients at risk of losing substantial volumes of fluid or blood. Okay, we've got a severe burn patient, all right? Are we going to be flooding them with fluids right away? No, but if we start seeing symptoms where they need it, then we will, right? So again, we've got the access if we need it. If we've got someone who's bleeding out, I mean, like they're hemorrhaging, you're putting on a tourniquet and stuff like that, are we going to be slamming them with fluids initially? Yeah. I mean, because you can see it. I mean, they've got at least 500 cc's of blood loss on the ground. Let's at least get that replaced and have lots of access to give them more if we need to, right? And blood. I mean, because when you know, you've got the capability of giving them fluids, but what are we going to be giving them when they get to the ER? We're going to be slamming them with blood. Okay, we have a rapid infuser called the Belmont that can deliver. If we've got a 16 gauge peripheral IV, we can give them up to 500 mils a minute. Okay, 500 mils a minute that we can give them. I mean, it is a rapid infuser that we literally dump, you know, let's see, 1, 2, 3, 4, 5 units. So we dump in 3 FFPs and 2 platelets. Or, I mean, we dump in the FFP and pack cells. 3 units of pack cells, 2 units of FFP. We dump it in this canister, and that thing is infused within minutes. Okay? So we can deliver up to 500 cc's of fluid a minute. Okay, and that's what we're giving. And why do we want to give them blood instead of fluid? How well does NS carry oxygen?
Not well.
It does. Okay, fluid just gives their heart something to pump again. But ultimately, what they need is they need blood. Okay, so that's why the rapid transport needs to always be at the back of your mind. Okay. And then routes for administration of medications, obviously. Most protocols advise administration of IV fluid in boluses of 20 to 30 mils per kilo in 250 to 500 mil increments. Do you know what? So this is your response if you know you're taking a test and this happens to be part of it. But just know that in the real world, okay, you're just going to start flooding it in, and then what are you watching? Reassess, 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 reassess. And the main thing you're watching is your pulse rate, okay? Okay, you've got a rapid pulse. It's bounding, okay? That rapid pulse could be from anxiety or pain. I've got a rapid pulse and it's thready. That rapid pulse is from volume. So you hit him with the volume and that rapid pulse comes down and the character of it improves. Okay? Then you can maybe slow it down. Now, 2 seconds later, your pulse is thready again. What do? Open it back up again. Okay? Do you see how this is a constant assess, reassess, treat, okay? You are never done till the minute you roll through those doors, okay? Special considerations in fluid resuscitation: administer only enough fluid to maintain radial pulses if increasing blood pressure is detrimental. So explain this to me. Why wouldn't I want to flood someone with fluids? What shock do I not want to flood with fluids, even if their blood pressure may be a little bit on the lower side?
Cardiogenic.
Cardiogenic. Okay? You could throw them into mass pulmonary edema if you hit them with too much fluid. So again, this is why it's so important. What is the cause of my shock? What is the cause of my shock? And am I treating it appropriately? Do I give them lots of fluids? Yes. In a volume depleted patient? Yes. In an obstructive patient or a patient in cardiogenic shock? Maybe not. I've got a pulse that is bounding, it's a little fast, my blood pressure is a little bit on the low side, but I can feel a good radial pulse. So I know my pressure's at least 80 to 90, okay? And so do you know what? I'm going to start my 2 IVs and I'm just going to run my fluids in TKO. Because right now, I'm good. I'm going to get this patient to the hospital. Okay? Because this patient has a history of an MI, and I think what I'm dealing with here is cardiogenic shock. And I remember in my lecture, I don't want to flood these patients because I could make it worse and put them into pulmonary edema. And now it's not just the pump that's failing, now the lungs are failing, and I don't want to cause worse problems, okay? So, only way to maintain fetal perfusion is to aggressively treat the mother. Oh my gosh, now we've got a pregnant woman who's in shock, okay? Are you treating 2 patients? Yes. Yes, you are. You're treating 2 patients. Okay? And how do you treat the baby? You treat the mother. You make sure that the mother is good, that the mother has got good perfusion and good circulation, because if the mom is treated, the baby is treated. And do you know what? The mom will suffer before the baby does. Okay? The mom will suffer before the baby does. That baby will keep up its perfusion even at the expense of the mom. They're little parasites. Okay? We as parents, we know that. And they will be, yes, and they will be parasites their entire life. Just so you know. Okay. All right. You guys doing okay? Let's take like just a 5-minute break, and then we'll come back and wrap this up. Okay. Get up, stretch, wake up a little bit. I think I'm good.
We get snacks back.
You have snacks?
Oh,
I
yeah.
need to see how much I have left there, so I can time. I get used to the timing of the lecture. Do you know what I mean? So
Yeah.
I'll traits like this one since I never taught it.
Yeah, we're all the same way, because this is all new stuff for us.
All new.
Yeah.
Yeah, I think we're good. We're on the last.
say you taught at Weber?
I did.
How long ago?
Ooh, that would be in the 80s.
Decades
80s
ago.
to 80s to early 90s maybe.
Okay. My former mother-in-law, she taught with
Who was it?
Rebecca Dickinson. So it would have been probably later 90s, early 2000s.
I taught Sally Brush and
Wow.
Bell and
Cindy, yeah.
Did you like the classroom this
Mhm.
morning? Did you like the new
Yeah.
configuration?
Yeah,
Yeah?
yeah.
Yeah. I like it.
Well, I came in and it was set up the other way, and I was.
This morning?
No.
Right.
A couple of weeks ago.
Yeah.
And they said, yeah, leave it that way because they're doing some class.
Yeah.
I said, okay, whatever, I won't touch you. You know, I don't know where it came from. Robert Free is gonna take care of that, and put it all in the cage.
I'm coming down tomorrow morning to work in the cage. I went to look for our EMT school supplies, and everything's been it's been pilfered.
Oh, really?
Our suction units are off. Our OB is gone. It's there. All the contents are gone. So there may be an email coming from me to.
I talked to Watkins about it
Yeah,
already. I told him,
I'm gonna
I
talk
said,
to
I don't know
Chris.
what's going on.
I think Chris may have taken a lot of shit up to you.
At 2020, yeah. Because I went to do an IO class. We didn't have any, well,
So
the IO class, we didn't have any of the bones.
you may see an email from me tonight or tomorrow asking where the stuff is. I'll probably phrase it stuff too. But you'll probably be included on it, just so you have knowledge of where it may be.
Our stretcher was missing, our stretcher and mannequin. You know where we found it?
No.
In IT, clear in the back. I don't know what the hell it was doing in there.
No. All right.
I know.
Well,
Take me down. You could, John.
Right? Right?
Mm-hmm.
I got skills.
You have skills. I have skills.
Yes? I've seen them.
I used rest control techniques more in the ER than I did 10 years at the sheriff's office.
Oh, yeah.
I think it's because they get surprised they don't take me.
Oh, yeah. Well, when I was working in the city, it was fun because I, just stand someone's drunk up and they'd go, how did you do that?
So
Can I scratch it for you?
So James was killed in a helicopter.
Oh.
Morning, James and Sherry.
Flagstaff.
Yeah, so, anyway, they, at LD, there's a street right out.
where is the endless supply of
Oh, okay.
And I said, here, Sherry, what is this?
I'm waiting to see.
Just stood in my, wrapped in the mother, and this was after 3 hours, and he looks over at me.
Bunch right out of just finished high school.
I thought James was gonna bust together and laugh so hard. He's like, oh.
Oh, yeah. Yeah.
All right, let's get started so we can finish this up in time.
January.
Lunchtime is rapidly, I'm sure, telling your stomach that it's approaching. Okay, so now we know about all the different types of shock, right? We know about the pathophysiology behind shock. We know what causes it. We know that there is several different kinds of shock, from cardiogenic to neurogenic to distributed to hypovolemic. So now let's treat these shocks, right? Let's treat them and make sure we know how to. Treating hypovolemic shock, let's start with that one. Obviously, control all external bleeding. There's no sense in flooding someone with fluid if they're just going to be pumping it right back out, right? So you're going to control all obvious external bleeding. En route to the ED, established one 18 gauge or larger peripheral IV. And, we love 16 gauges. We really do. And I've started my share of 14 gauges. They've kind of come out of vogue. And a lot of people aren't doing it, but you know what? If you've got someone who's bleeding out, and you can. So, you know the grinding blade story that I told you about that went in the femoral artery and the guy was bleeding out? So, this was one of my first patients right out of paramedic school. And I was working as a paramedic on the ambulance because I hadn't been hired yet by the sheriff's office and sent to the police academy. So I had my red patch, but I was still in the ambulance because I wasn't old enough to work for as a deputy sheriff. And the paramedic truck was in Farmington, and we were clear out in West Clearfield, okay, out by the Freeport Center. This guy was bleeding out, had this big old blades, and we had no idea how much was in there. All we know is that when we got there, he's in a pool of blood and pretty much resting. I started a 14 gauge on this guy. And it turned out to be the only IV he had the entire time through surgery, and this guy survived. And he literally bled out. And I mean, it was just, and it was one of those type of IVs, you know what I mean? And I have no idea how I found it, but I did. And got a 14 gauge in this guy, and they were able to give him tons and tons of blood. And they tried in the ER several times to get another line on him and could never get another one. And ended up just hurrying to take him to the OR, and that was his one line. And he probably still had just enough vascularization that I could fill that puppy and pop away. So do you know what? Don't be too awfully afraid, because I know they look really intimidating. But an 18 gauge is minimum. Okay. So, and do you see how it says en route to the ED? We're talking of hypovolemia, so this is the person bleeding out. In other words, we're not even wasting our time at the scene to get a line established. We are getting these lines in and getting to the hospital, because what is the treatment for hypovolemic shock? Blood, and then surgery to fix whatever it is they're bleeding from, okay? So delayed transport is not your friend. Secure and maintain an airway and provide respiratory support. Most of the time this just means apply a non-rebreather, okay? But if you've got a bag of the patient, do it, okay? And your other lectures will go over more and discuss when that's appropriate. Do not give the patient anything by mouth. I'm so thirsty, can't you give me a drink, can't you give me a drink? Do you give them anything? No, why?
We're going to go into
Surgery.
Yeah, they're probably going to be going to surgery, okay? Plus they have a tendency to vomit. Do you know what one of the first symptoms of dropping your blood pressure is?
Vomiting.
Okay, they throw up. Someone who drops their blood pressure really suddenly, one of the first symptoms they'll tell you is super nausea. And they'll oftentimes vomit. And that should be a signal to you right there that says, check your blood pressure, you probably just dropped it. Okay? Monitor the patient's mental status, pulse rate, blood pressure. Remember, the blood pressure it's compensated shock right up until when you start to drop your blood pressure, then it's decompensated. Again, provide rapid transport. And that may be calling a helicopter. I don't know where you guys are all from, but in Davis County, we utilized air services a lot. Because we don't have it, especially at the time, we didn't have any kind of trauma center with any close distance to us. LDS Hospital in the U was it. McKay was a trauma too at the time. So anyway, so we used the helicopters a lot. So think about that right off the bat. If you're far, far away, if you're in one of those places that you're kind of in an obscure area, to get a chopper coming. So let's treat cardiogenic shock, okay? And again, we talked about this a little bit. Ensure that your systolic pressure greater than 90 millimeters before administering any nitroglycerin, because could your cardiogenic shock be actually having an MI at the time and having chest pain?
Absolutely.
Yes. So do you treat them like you would an MI patient, chest pain, nitroglycerin, etc. Yes, so you do, but you want to make sure that your pressure, because what does nitroglycerin do? Yeah, so, okay, what are the causes of shock? Bad vessels, bad pump, bad volume. So now you've just added bad vessels on top of bad pump, right? So you've just compounded your problem here. So make sure your pressures are adequate to be able to give nitroglycerin. Place the patient in position of comfort, administer high flow oxygen, provide prompt transport. You want to still get your IV access, but administer your fluid at a TKO rate, because we do not want to flood this already failing pump. Okay? Everyone understand the physiology and rationale behind that? We're good. Okay, obstructive shock. Okay, what is the main goal for treating obstructive shock? Relieve the obstruction. Now, as advanced EMTs, you may not have the skills or the teaching to do that, or the license to be able to do that. So you want to get them to an advanced practice, or to get your advanced practice there. So if you're on an engine, you've just been dispatched on a BLS engine, and you feel like what you've got going in is obstructive shock, then you either want to rapid transport or get your higher medical authority there to be able to relieve the obstruction. So in the case of cardiac tamponade, back when I went to paramedic school, we were actually taught how to relieve cardiac tamponades. We did pericardiocentesis. We were taught how to do it. I still to this day know how to do a pericardiocentesis. Okay? Now, that's not so much. Got to get them to the hospital. Okay? Pericardiocentesis is when a needle, we usually use like a spinal needle or a large, long angio needle, is inserted subxiphoid or fourth and fifth intercostal space. We withdraw on a syringe until we get a blood fluid, and even relieving 20 cc's off that pericardial sac makes a huge difference. All of a sudden, their pressures come up, their pulses are good, we see a change in their level of consciousness. So in this one, the tamponade needs to be relieved. Since you guys can't do it, who can? You get them to the place who can. So it's supportive until you can get them to the place that can relieve that. High flow oxygen. Are you still going to give your
Absolutely.
IVs and fluid?
Yes.
Fluid only if they need it,
Getting
but
the
chances
IV.
are you may only need to run a TKO, because your goal is to just try to maintain a normal, adequate blood pressure. In other words, I've got a good read on pulse. Okay. Tension pneumothorax. Okay. Apply high flow oxygen via non-rebreathing mask. Are you guys allowed to do decompression, needle decompressions? I think not. I'm actually not sure. So, but ultimately that's what needs to be done. So the paramedics in the field will do the needle decompression of the chest, and ultimately what do we do in the ER? Chest tubes. We put in a chest tube, okay? So we need to relieve the obstruction. So that, with obstructive shock, we need to relieve the, so provide decompression of the injured side of the chest, gain IV access, medication, administer fluid at a TKO rate, or faster if indicated. Okay, so do you see the one where you're flooding with volume is the hypovolemia, the rest of them? You're watching, right? And administering as needed. Pulmonary embolus, that's an obstruction that we really can't think, I mean, they'll end up either in surgery, but they get heparin and stuff, or try to dissolve that clot. Assess blood pressure, provide a fluid bolus of 250 mils of crystalloid solution, and again, it's just mostly rapid transport. Treat their symptoms, okay? Treat that patient. Treating septic shock, all right? Use appropriate standard precautions. So again, how are you going to identify that what you're treating is septic shock? Temperature? History. Okay? History is your friend. All right? History is your friend in this one. And why is this one of importance to you and your safety?
What do they have?
What do they have? Okay? You've got an 18-year-old male. He has a temperature of 40.2. That's high, by the way. Okay? He has a temperature of 40.2. His pulse rate is 120. His blood pressure is 96/50. Okay? You're getting history and says he just hasn't been acting right. He's had a horrible headache. And now you've got this kid coming in. Why is that a threat to you? It could be contagious, whether it's a viral or bacterial. If it's meningococcal meningitis, do you know what? You're going to be on antibiotics for the next 3 days. You could possibly bring that home to your family. Is this a good idea to get a good history on what's causing these symptoms? Yes, and I give you this example because we had a paramedic unit bring a patient in like this. Okay? Has a history of a headache. He's got a decreased level of consciousness. They never did check a temp. They came in completely, no precautions, all right? We didn't get the heads up because we were not told of any fever. I'm in there, I'm reaching in to grab him to do my quick assessment, and I'm thinking, ooh, dang, he's hot. I grabbed it to 40.2. History of a headache, but, you know, mask up everybody. And sure enough, he had meningococcal meningitis. I was on my pamphlet for 3 days after that. Paramedics were totally unprotected. And because of their lack of getting that history, it also put us in jeopardy. Okay? So, use appropriate standard precautions and transport as promptly as possible. High flow oxygen, IV access, administer fluid to maintain radial pulses. And again, here, treat your patients. Not everybody gets the standard, okay? You give them a fluid bolus if they need it. If their pulse is weak and thready, they get a fluid bolus. If their pulse is bounding, okay, nice and strong, it's TKO. If they've got a high fever, if they've got a high respiratory rate, do you know what? They could use some fluids. Okay? Because they're losing fluids just through their respiratory rate and the fact that they're burning it off with this high fever. Okay? Fluid bolus is not going to hurt them. Neurogenic shock, okay? This is the hard one sometimes. And again, how are you going to determine if this is a neurogenic shock? What is the mechanism of injury? Okay, what is the mechanism of injury here? Best treated by combination of all known supportive measures. You're going to do it all. Okay? You're going to two large bore IVs. You're going to hang fluids on them, and you may be doing bolus down, trying to keep this thing, but ultimately what they need is vasopressors, okay? But you're kind of watching this patient, but basically are you going to be messing around at the scene for very long with this guy? No. To the hospital, okay? Emergency treatment must be directed at obtaining and maintaining a proper airway, spinal immobilization. Adequate breathing is needed, okay? If it's a high C-spine fracture, you may be doing what? Bagging them. Because they're not going to have a respiratory drive. Okay? Conserving body heat, providing the most effective circulation possible. Okay, so spinal circulation, warm fluids, you may be having to bag them and treat them. And if their blood pressure is 90/40 and their pulse rate is 150, are you going to give them fluids? Yeah. Because you may not know for sure what's going on. Is there a possibility that you could have a hypovolemic shock going on inside here if you've got multiple trauma? Absolutely. So do you know what? Your job is not to diagnose that, oh, this must be a neurogenic shock. You know, because I'm worried about C-spine because he's not breathing or whatnot. You may still have other things involved. Okay? So if your vital signs warrant fluids, give it to him. Give it to him. And you know what? If you overhydrate him, guess what? We can pull it off. Okay? We can pull it off if we have to. But if what their vital signs are dictating is that they've got a low blood pressure, they've got a rapid heart rate, they've got a weak pulse, you're thinking you may have spinal cord involvement, you're not sure if it's hypovolemic or neurogenic, you know what, treat them as if it's hypovolemic. Okay, so, because it could be both. Treating anaphylactic shock. This is another one. This is a shock that can go boom this fast. Okay, these people can go from minor symptoms to like what happened to emergency crank them because their shock goes so fast. Okay, administer epinephrine, subcutaneous or intramuscular. Most of the shift now is IM. Okay, we've gone from sub-Q to IM. So make sure you do not give it IV. Okay, there have been those mistakes made where epi 1 to 1,000 is given IV. If you give 0.1 of 1 to 1,000, what's cardiac epi? 1 to 10,000. Okay, so yeah. So make sure that you are giving it the correct route. So again, these mistakes have been made. Okay, so I am epi. Okay, that's why they come in little pens. All right. Promptly transport while providing all possible support, which may include intubation by the paramedics if you cannot support the airway. If you've got someone who really has a threatened airway, if you guys have access to a keen or an LMA or something like that, you may want to keep that handy. All right. And it obviously gain IV access. We'll give a lot of other medications on top of the epi. We give epi and Benadryl, and we give Pepsid. Well, Pepsid, that's for, acid indigestion. We give IV Pepsid. And Solumedrol, which is which is like a steroid to reduce the body's inflammation. That's kind of our allergic reaction cocktail that we give. Psychogenic shock, right? How do we treat psychogenic shock?
What it called out.
It's supportive, right? It's supportive. Obviously, you're probably called after the fall, all right? So they're already on the ground. So as far as your treatment goes, your treatment's going to focus on, did they injure themselves in the syncope, right? Any related injuries to that syncope, to that fainting, okay, as a result of that psychogenic shock episode. Again, record the initial observations of vital signs, level of consciousness, try to get information from the bystanders. That's going to be your best tool. What happened here? Well, she was just told that her mother was killed in a car accident. She suddenly got super pale, and she just went down. We were able to kind of catch her, so she didn't hit her. So did she hit her head at all? No, we were able to kind of help guide her to the ground. And now she's kind of waking up, and she's crying and whatnot. So your treatment is going to be what? Supportive. You check her vital signs. Her pulse is 102. It's bounding. Her blood pressure is 118 over 78. So it's going to be one of those things that you could even possibly end up releasing this patient, right? They just kind of tend to come to, you doing okay? Have you had any injuries? No, I'm okay. So again, your treatment is supportive. You're going to look for mostly what preceded it. Is there something more that could have happened? Could they have had a seizure prior, and that's what caused them to go down? Again, get a good history and don't always assume. Remember, assume makes what? An ass out of you and me, right? So you need to make sure that your assessment skills and your history taking, history is so important, okay? Treating respiratory insufficiency, okay? So here we're talking about any shocks related to respiratory problems. Immediately seal any hole in the chest. What are we talking about here that could be causing it? A gunshot, a sucking chest wound, right? A sucking chest wound, which will eventually lead to what? A tension pneumothorax. Okay, a sucking chest wound that goes untreated will lead to a tension pneumothorax. Okay, And so you want to seal any chest. They have those flutter valves, the little sticky-on kind that has the one-way valve that allows air to go out and doesn't allow air to go in. Did you know you can make one of those out of the finger of your glove? You can take the finger of a latex glove, cut a hole in the top, take that around the hole and try to sew it that way, and you can also kind of try to make a flutter valve out of the finger of your glove. Also, a three-sided dressing. You all learned that in your EMT class. You know the Vaseline gauze with the foil? Okay, leave the Vaseline gauze inside the foil and just put the foil on top and tape three sides. That also helps allow air to exhale but not come back in. So, again, do what you can to help prevent any further degeneration of this respiratory system, okay? Stabilize impaled objects. You don't want to pull those suckers out, right? Or then you for sure have a sucking chest wound. Secure and maintain the airway, administer supplemental oxygen, and determine the need to assist ventilations. All right, is the respiratory rate, depth, and character adequate? What's their perfusion? What does my patient look like? Okay, can you bag someone who's breathing? Yeah, it's called supportive ventilation. Okay, so yes, you can bag someone who is breathing. Someone who's breathing at a rate of 4 per minute, is that adequate? Nope. Nope. Okay. Guess what? We're done. So, in the back of your book, I know you have all these little assessment and actions at the end of chapter 14. So, I don't know if you guys want to review any of that. I would be happy to stay and do that if you'd like to. There's, I know there's the quiz questions through there. I would be happy to review any of those if you have anything, or any other questions, or if you guys would like to just say, I'm hungry, I'm done, my brain is full, and I want to be finished. I'm good either way. So, first of all, how do you feel?
Very good.
Feel good? Do you feel like you have a better understanding of shock?
Yes.
Do you understand the physiology of what's going on with shock?
Better
Do you
now.
know the definition of shock? Do you know the different types of shock? Can you recognize the different types of shock? And do you understand and know the appropriate treatments for each? Working on it, right? Do you know what? You're never, I've been in emergency medicine for 36 years, and I'm still learning. So, okay.
Thank you.
Yes,
Thank you.
You're welcome. My pleasure. And I think I see you guys one more time.
Fantastic.
So, I think I'm teaching a neurological emergency actually for you guys.
Great.
Okay?
Perfect.
All right.
Thank you.
Thank you.
You're welcome.
That's pretty good for the first time.
John?
Is there any chance that anybody can trade days on this? Or is that the only day that everyone?
Yeah.
Really? Very good.
Really appreciate what
Yeah,
you mentioned.
I like to teach,
You got
so.
Well, and it definitely shows. So thank you very much.
Thank you, it's great.
Tell John, tell him he needs to give me a raise.
These are right.
Pardon me, I'm sorry.
Everything teach the whole class.
Yeah, you know, I would.
There's really like probably 60 questions or whatever. I would like all of the JV learning ones to be open, because that'll give us the bigger range of questions to like go to and take.
Can we open that?
Oh yeah, Kurt totally can, because he's got the,
Open it up, man.
let me see if I can find it. So what I did,
That hurt.
I know, so on my BNT, so when after I take the quizzes, oh, the other thing is those are interactive and they can help me allow the explanations. And so it'll say, you missed this one because why? Oh my goodness, I love that. So
Where's
on
that?
What's that?
Where's that? The explanation?
On the JV learning one.
Oh.
So those have the opportunity to get the explanations for it versus what they're importing into Canvas.
Right, because I'm like, I don't know.
And so at the end of it, so here's all the different chapters that we've had.
Right.
And so then I would just, like, I had it, I just copied it, pasted it, and I wrote a formula just to pull out the questions and the answers.
Right.
And created a huge bank of questions and answers.
Oh, nice.
Does that make sense? And so I could go through and go, oh, I'm totally not remembering this, and why that's the answer.
Right.
And so it was super helpful. So by the end of it, by the time you're done.
On your way? Come on over.
Yeah, you can look.
Come on over.
Come on over. I mean, I have 54 pages of questions and answers that created a bank.
Yeah.
Because I could study them.
Absolutely.
So I would love for him to open up. Hey, the resource for it too, so you can get
John?
additional.
Yeah, hang
You have
on just a
access.
second.
All right.
Oh, okay. Nancy's gone.
You have access to the JV Learning.
Yes,
Can you open up the test questions with questions and answers and explanations? Make that
On the
accessible?
JV learning part.
I don't know, I've got the same access that you have.
Oh, okay.
I don't have
Leave it
anything.
now, that gives me all the access to stuff.
So, for example,
Want me to tell him? I'll tell him. He needs to open that up. That's just a good resource for us, a good study resource.
I know.
Especially if that's gonna be a bunch of the exposure to the national registry.
Test.
It
Yeah.
doesn't really have
I
the
mean,
explanations,
I'll-
right?
I'll tell you, I know I'll pass this class,
so there's like.
but I don't have to
chapters
take
on
national registry to get my 9 credit hours, but I'd like to.
Right, right, exactly.
And if I'm gonna take it, I'd like to be prepared for it. And having access to all that, that'd be a huge benefit to us.
Yep.
So when he's all done